everyone, welcome to researchmd.com. We got a great topic today. We're going to teach you everything about appendicitis. All of our presentation is under 9 minutes. Repetition is the key. We understand that rather than giving you an hour-long presentation and then if you don't repeat it, it's not going to hold off into your brain, okay? So our topic is going to be under 9 minutes, evidence-based. Again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency program, transitional residency program, and I teach medical students and medical residents. So let's get into our subject. So what is appendicitis? Definition: inflammation of the appendix, which is reported to be one of the most common abdominal emergencies worldwide. Untreated, you can call like abscess, gangrene, rupture, a lot of complications, okay? Most common age is between age 10 and 30 years, and 7 to 14% their lifetime prevalence in the United States. Overall incidence 11 cases per 10,000 population per year. Again, we talked about the complication. Perforation is around 17 to 40%, but when it comes to elderly patient, it's extremely high, like 60 to 70%. In elderly patient, mortality is like 5 to 15%, but if you like in the younger people, mortality is very low if it is treated, okay? So anatomy, the base of the appendix, usually located 2 centimeters below the ileocecal valve in the right lower quadrant, but the tip may be varying location. So there's some positions you may want to know. 75% of the time it's like retrocecal, pelvic is 20%, behind the peritoneum is like 5%, okay? So they vary in the locations. Pathogenesis, if you look at, there's luminal obstruction with the fecal lid, that's the initial, and then distension that causes bacterial overgrowth, increased intraluminal pressure, followed by decreased capillary blood flow, ischemia and inflammation, and then all the complications of the untreated can develop. Okay, the causes not very clear. Common theories like luminal obstruction, typically by fecal lid, lymphoid hyperplasia, or even impacted stool. Signs and symptoms: abdominal pain that begins in the central abdomen, the periumbilical abdominal pain, migration, that's the word we have to use. So migrate to the lower right quadrant as the inflammatory process progresses. Tenderness to palpation in the affected area, nausea, vomiting, low-grade fever. And when you have a right lower quadrant pain, the likelihood ratio is almost like 7.3. That means 30 to 40% high risk of problems, okay? In the diagnostic maneuver, you got McBurney's sign, you got Rovsing sign, Zoe's stretch sign, and you got obturator sign. So those are the 4 signs you need to know. Well, so let's look at each one. This McBurney's sign is the deep tenderness is present at the point 2/3 distance between the umbilicus and the right hip bone. That's the point of like maximum tenderness. That is McBurney's sign. Then you got Rovsing sign, pain in the area of maximum tenderness with the percussion or palpation of the left lower quadrant, and then you got stretching of the psoas muscle, which is called a psoas stretch sign. You got right lower quadrant pain with the right hip extension, typical of retrocecal appendix. And then you have finally the obturator sign, right lower quadrant pain with the flexion and internal rotation of the right hip. It could be dependent on the location of the appendix in relation to those muscles as well as the degree of inflammation. So those 4 signs you need to know: McBurney sign, Rovsing sign, So's sign, and obturator sign, okay? Now, the next slide is we kind of give you the sensitivity and specificity of each one, okay? So McBurney sign is 83% sensitive and specificity 45%. Rovsing sign, sensitivity from 19 to 75% and specificity 58 to 93%. And Zoe's sign 13 to 42% and specificity is at almost like 97%. And obturator, you got 8% and 94% respectively. It's good to know each of the tests, like, what is the sensitivity and specificity. And if you look at the likelihood ratio of the symptoms, you can say right lower quadrant pain, we already said like highest likelihood ratio. Migrating pain, you got 3.2. Zoe's sign got positive likelihood ratio 2.4, and rigidity got 3.8 positive likelihood ratio. All of this positive likelihood ratio, you may be converted into odds, and you can say when you have the symptoms, like let's say right lower quadrant pain is like 8, you can pretty much say like 30 to 40% higher odds of having appendicitis. So it's good to know the numbers. And anything you can express in numbers, that means you know it very clearly. Okay, so the diagnosis mainly by classic presentation of history and physical examination, all of the signs we talked about it. You can do the blood test to see if there is leukocytosis. Then there's some imaging studies to confirm it. So we're going to go over all of it. So CBC, CRP, bilirubin level. I mean, everybody knows CBC, CRP, but people usually forget to check the bilirubin. Please check bilirubin. It can, if there is hyperbilirubinemia, that means there is associated with gangrene or perforation. Okay, so we put the sensitivity and specificity of the leukocyte count and CRP right there, but don't forget to check the bilirubin. A lot of people forget to do that. Now, CT scan. If you look at the sensitivity and specificity, it's pretty high, around 98% to 99%. Very good test. Okay, in ultrasound also you can do. Sensitivity is a little bit lower, but specificity is almost like 87%. So there is another scoring system called Alvarado score. Okay, so you got like abdominal pain that migrate to the right iliac fossa, 1 point. Anorexia, you got 1 point. Nausea, vomiting, 1 point. Tenderness in the right iliac fossa, 2 point. And then signs, rebound tenderness, 1 point. And then leukocytosis, 2 point. Neutrophilia, like 1. So score of 5 to 6 is comparable with the diagnostic of appendicitis, and score 9 to 10 is very probability. So you can calculate the Alvarado score. So let's look at what is the sensitivity and specificity. Sensitivity is around 93.5% for Alvarado score, and the specificity is like 80.6%. Okay. Treatment, mainly control the pain, and followed by antibiotic and the surgery. Those are the main three. The more we delay the surgery, you can have like more complications. Again, the antibiotic choice, you can use sulfoxetine, sulfofitan in combination. So mainly the pain control, fluids, appendectomy, you need to call the surgeons and do appendectomy before the complications develop. If there is perforation or abscess, you need to surgery like right away. And the complications, again, we talk about abscess, gangrene, perforation. Thank you so much for watching. We'll be back with another presentation soon. Thank you.